Welcome to the Sports Science Dudes. I'm your host, Dr. Jose Antonio, with my co-host, Dr. Tony Ricci. If you're a first-time listener, hit the subscribe button, like the show. We're on YouTube, Rumble, Apple Podcasts, and Spotify. And today we have two special guests. First, I want to mention the bald one on the left. Oh, wait a minute. Sorry, that's all of us. Dr. Edwin Davila. Did I say that right? Davila or Davila?
Works both ways. I go by that.
He is a DO. He also has a master's degree, and he is a CISSN. He's a senior resident of internal medicine, and I hope I get this right, at the Texas Institute for Graduate Medical Education and Research. Is that correct?
That's it.
In San Antonio, where, by the way, if you've seen the Alamo, it's actually quite unimpressive. It's like this tall. I don't know why. I was like so excited to see the Alamo. I see it, and I'm like, holy smokes, that thing is, I think it's like the size of my house.
Yeah, and it's attached to a Starbucks, which is even more depressing.
Exactly. So Dr. Davila, he got his MS degree in exercise physiology at Baylor University. I think that's where he met Dr. Darren Willoughby. He got his BS in biology at Baylor University as well. He's on the board of directors for Texas ACSM. He's also an AMSSM board member. And also, this is pretty cool. You were in the U.S. Navy?
Yes, sir.
Oh,
okay.
Fantastic.
Well, we'll have to hear a little bit about that. And also, your focus has been on obesity medicine and associated comorbidities. Dr. Escalante has actually been on the show before, so we're excited to have him back again. He's currently the assistant dean and professor of kinesiology for the College of Natural Sciences at Cal State University in San Bernardino. He is highly published, and certainly one of his bread and butter topics that he loves to talk about are performance-enhancing drugs, androgens, et cetera, et cetera. He's also currently the vice president of the International Society of Sports Nutrition. So I'd like to welcome you both to the show. It's great to have you. And I know this is a meeting of four gentlemen who go to the same barber. So
thanks for having us again, for having me again, Jose, and great to see you again, Dr. Davila. It was nice to meet you at the ISSN conference. And, we actually came from a similar part we lived at the same region in Southern Texas for a little bit, we found out. Because I used to live in Southern Texas for about 5 years, and he's from that same area. So pretty cool.
What's interesting? The four of us have been in Texas. I mean, Tony, you live there. I lived there for 10 years. I went to UT Southwestern. I love the state of Texas. I mean, it's a state.
11 years I was there. It's still the best country in the United States.
Or none.
That is true. That is true. Okay, Edwin, well, tell us a little about you. We're a naval officer, which is an unusual, it's a background that you don't find often in our field. Tell us a little bit about that.
Yeah, sure. Well, first off, thanks for having me. It was awesome being at ISSN this year. And when you said, hey, you want to come on board, I was like, heck yeah, I want to come. This is going to be fun. What took me down into being in the Navy actually was I was from a real small town in South Texas, population 800. No one knows that's even there. And, there's the whole concept of you want to see the world, you want to go and kind of try something new. But my family wanted me to go to college first. So went to Baylor, got my undergrad there, and I still wanted to join the Navy. So I applied. Again, you'll see the world, you'll go do everything. First duty station, San Antonio, Texas. And I was like, second fun thing about that, they said, tell me the thing you don't want to do. Oh, I mean, I'd love to do anything, but I don't think I like submarines too much. Gotcha, not a problem. I rode 4 submarines.
Oh my God. Well, you saw a lot of, I can't imagine in a submarine, it's got to be so compact that if you're claustrophobic, forget it, right?
Oh, they'll break you with that, but they're clever. They're clever. It's technically volunteer. And first, I love my Navy, so I would never pass it up for the world to do it again. But they're like, well, you know what? Maybe you're a little claustrophobic. Let's send you on what they call a Tiger cruise, which is kind of a go on there, make sure you're okay, make sure you can handle it. But they sent me on the USS Florida, which is an Ohio class. Think of it as the Ritz-Carlton of the submarine world. The thing is humongous. So you're just like, oh, what's the big deal? Everybody keeps talking about these things are tiny. It's not, sign me up, whatever. Then they sent me on 3 Los Angeles class submarines. After that, think of LA's being the smallest Motel 6 on the planet. Wow. Where, I'm just like, well played. Well played. I'm not even mad at this.
Well, I don't know if you saw the world, but you saw a lot of something. So
Fall out of the wall.
that's so funny. Hey, Guillermo, so what's up with you this summer? Summer's usually kind of a downtime for us academic types. So what's new with you?
Yeah, well, with this new administrative position, I'm here working a lot with students and doing student success type stuff and overseeing our science success centers. It's pretty busy on this end, but I actually we're doing a little bit of data collection on a study that I'm collaborating with one of our assistant professors. So he's leading the way. I'm just kind of helping. It's a squat study looking at EMG and looking at joint kinematics. So that'll be pretty interesting. We're collecting some data on that, and then I'm also just publishing some stuff that I collected from a few years ago on bodybuilding related data. So we're working on getting some of those pubs out. And then I'm also working with Arnie Ferrando on an androgen paper that we did on rats. They collected some data on rats. So I'm writing up the intro, and then now the results are in. So now we're kind of looking at everything here and seeing what's going on that aspect. So still staying busy in the manuscript writing stuff. And then of course I'm going to NSCA next week, and then a little vacation time in between now and then back to school in August. So yeah, it'll be a short break.
Awesome. Well, let's start with this. In the news, we've heard a lot about Ozempic and all of these GLP-1 receptor agonists. And I was actually surprised just starting to self-educate on this topic that there are a multitude of drugs that fall under this category. So I guess start from the position of the audience isn't really familiar with this drug. They've only heard about it in social media. People lose weight, blah, blah, blah. But then I'm also hearing people feel sick. They have crazy side effects. Give us a bird's eye view of what this drug does.
Of course. So GLP-1s or glucagon-like 1 peptides fall into a class of just what's called incretins. It's a class of hormones that our body naturally produces that has a glucose-dependent insulin release. So why that became so important was it tied into our evolution of understanding of diabetes. And it's important to mention or important to know that these medications have actually been around for quite a long time. We actually first identified GLP-1s per the literature almost 100 years ago. But what we've seen and why they became so popular in the diabetes world is as we learn more about diabetes, we realize that the dysfunctions or the systemic dysfunctions were not just tied to skeletal muscle, the pancreas, and adipose tissue. It actually had multi-systems. Dr. Ralph DeFranzo of the Texas Diabetes Institute in San Antonio is kind of a group who is basically the GOAT of diabetes. Kind of coined the term ominous octet, describing 8 different systems that are dysfunctional in diabetes. So research went in to find what are the dysfunctions and how can we treat them. And sure enough, once they discovered the GLP-1s and kind of dive further in there, they realized that the areas in which the body has dysfunction during diabetes, they have receptors that GLP-1 actually it promotes an improvement in those dysfunctions. So it constantly was in that realm, diabetes. The first one that really came to market was something called Byetta, which was a daily injectable medication. The reason you didn't hear much about it because they really weren't showing a lot of success in weight loss. It was kind of there, but no, yeah, whatever. We saw the same level that they were getting with phentermine.
Sorry to interrupt you. This is just to clarify, it's type 2 diabetes, right?
Correct. And that's extremely important.
Right. And was weight loss ever a clinical endpoint that they were looking at? Or is it a second? Oh, no. Okay.
No, it was almost an accident where individuals, they started to notice the patients who had type 2 diabetes in the trials that they were looking at the improvements in things like A1C, fasting glucose, blood pressure, dyslipidemia. They also noted improvement in weight. So it actually pushed the ball, if you will, over the hill and said, okay, well, are these people losing weight because they're diabetics and the improvement in the diabetes is causing an improvement in the weight, or is there something separate? So then new trials came out that actually looked into patients with purely obesity without diabetes. And that's why it became that's really what spurred it is the STEP trial, which was pretty much the first one to kind of really look at just obesity, no diabetes, and they saw pretty substantial weight loss from it.
Now, I find it odd. I guess when you're looking at people who are obese, I assume they're using BMI as the as the cutoff, and I would imagine is what, 30 or 35? I'm not sure.
So the pretty much all the trials kind of looked or defined it the same way, with a BMI greater than 30 or a BMI greater than 27 with an associated comorbidity. So that would include things like diabetes, not in this one, not type 2, dyslipidemia, hypertension, metabolic syndrome, things of that nature. So it's either of those two.
Okay.
Tony, I
Tony,
have a question, Edwin, real quick, with regards to the because I know there are people that are not obese that are utilizing, this drug,
yeah.
In the bodybuilding fitness component, and they read this in the clinical trials. So, what do you know in terms of the efficacy on those that, maybe just need to lose, say they're not obese, but just lose 10, 15 pounds of body fat, so that, what about that population?
great question.
So that right there is really what kind of spurred the interest of, not because all the data right now is looking at just the clinical population of obese. We have no actual data to say how this will affect somebody with, let's say, normal weight. Also, taking point is we were only looking at, not we, but the scientific community, we're looking at patients who clinically met obesity per BMI. So not looking into the physical body composition of the individuals. But unfortunately, because it being what it is and people's drive to have any kind of edge when it comes to weight loss, we have been seeing a rise in the amount of patients who are being prescribed GLP-1s without the clinical definition of obesity. And it kind of spends what you were mentioning, Dr. Antonio, about the side effect profile is in the trials, the side effects were actually relatively low with these patient population, depending upon the dosages they went with the respective medications. But anecdotally, what I've been seeing that patients who are taking these who do not meet clinical criteria for obesity, who are just trying to lose what some would call the, I think the term is the beauty pounds or the, trying to think of a better word for that, but just trying to get that loss, they're actually seeing quite a bit of side effects. But it brings a question as to why, though. Because a lot of patients who are taking these who don't meet clinical criteria are getting them from secondhand sources. They're not the legitimate semaglutide, which is Ozempic / Wegovy. These are compounded medications they're getting. And that's a whole nother area that is now becoming a point of contention.
Well, what are some of the common side effects you might see with the obese population? Then I guess, since you don't have data on, I'll call them normal weight individuals, what are the, I guess, anecdotal reports of side effects in that group?
So the most common side effects are GI related, nausea, vomiting. And the reason for it is the effect in which GLP-1s have systemically. So looking just at the level of the GI, they decrease or slow gastric emptying. So what we've noted is individuals who are still trying to meet that habitual dietary intake, large volumes or whatever they're usually used to eating, they're still eating with their eyes instead of kind of letting their body decide how they want it, how much they need. They're actually having quite a bit of nausea, which stands to reason. If you're having a slowing of gastric emptying, but you're still having the severe oral intake, you're going to have dysfunction. And secondly, we're noticing too, to kind of go towards that emetic effect is these medications or this particular compound, it passes the blood-brain barrier, and it affects an area of the brain called the nucleus tractus solitarius in the caudal brainstem, and that's an area of the brain that controls energy homeostasis. So when it hits there and it's telling the body in two different ways, we have an energy surplus, we're good, but the habits haven't really dug in yet with the person. They're kind of trying to override it, nausea, vomiting, but it improves once the patient begins to try to start listening more to the cues that they're actually supposed to be eating, and it gets better. The big ones that you will hear is individuals who had a history of pancreatitis. It's a contraindication. It's been extremely low that we've seen it, but we have seen a few issues of acute pancreatitis. And while we haven't seen this in human trials, anybody with medullary thyroid cancer or multiple endocrine neoplasia type 2 or MEN2, they are completely contraindicated, but that's purely from what we've seen in rat trials. There haven't been any direct associations, but it is a black box warning, so we stand to reason we don't do it.
Guillermo, has this hit the bodybuilding community yet in terms of widespread use?
I think it's been trickling in. I think some coaches are beginning to use it, and some of the athletes, of course. And then where I see it a lot though is actually kind of like what Edwin was saying was with these like I'm going to say like the beauty clinics where you go get Botox and all this other stuff. So you have nurse practitioners or, maybe a physician-owned practice. And I mean, there's a lot of these clinics that are prescribing it to people that don't meet the clinical criteria for obesity whatsoever. I mean, they're literally women that are, look by all standards, that are in pretty good shape, and they just want to lose that extra, 10 pounds of body fat.
Yeah. The unfortunate thing about that is it created this kind of like a pharmaceutical arms race when it comes to individuals wanting to have that next big thing in vanity pounds. That's what I was looking for. But what's unfortunate is for that patient population who don't meet criteria and have to pay out of pocket, things like semaglutide or tirzepatide, which are the two big ones right now, out of pocket, no insurance, those cost about $1,400 a month. But these compound pharmacies are selling these things that are, oh, it's the same thing for $150 a month. But the fact of the matter is these medications are not been FDA approved. We don't know where they're getting the raws from. These peptides are coming from God knows where. And funny enough, the two individuals who own the peptides, which is Novo Nordisk and Lilly, they're actually having nationwide lawsuits now against these spas and these clinics that are selling these medications.
Yeah, absolutely. And one other criteria that I think it concerns bodybuilders is, how much fat-free mass am I going to lose? How much lean tissue am I going to lose? So even though you may be losing the body fat, but at what expense? So I think that's another thing that you have to kind of consider, especially if you're really in the physique sport or sports in general.
I'm sorry, go ahead, Tony.
Guillermo, thank you. That was my question to Edwin too. I mean, so at the rate of weight loss with or without, do we see, Edwin, a greater propensity? Because I'm assuming a lot of the people are not, we're assuming they're not training, they're not actively eating enough protein for lean tissue preservation. So would we see a normal rate of lean tissue loss with the drug, with all things being equal? Or some of what I read earlier is that there's a propensity for greater lean tissue loss with the drug use than there would be at the same rate of weight loss in its absence. And I don't know if that's correct, but just something I think everybody would like to know about.
Absolutely. And funny enough is I think that with this basically evolution of this medication being used so much in multiple ways, it's actually driving more of this research to kind of fill this gaps. Because right now we do have an official gap into in terms of this quantity of muscle loss. But what we do know from previous trials is there was a trial looking at one of the previous ones that was most widely known. The very first one that GLP-1s that was approved for weight loss was called liraglutide. For the diabetic world, it's called Victoza, but if you get it for obese, it's called Saxenda. A trial was done to look at how much of the weight loss that they're seeing with it was fat, or how much of it is just weight. So they broke into a parallel trial of individuals, gave them 8 weeks of a very hypocaloric diet, which it was an 800-calorie diet. I had problems with that to begin with, but it is what it is. And what they did is they wanted to observe as to how much at the end of the actual start of the trial was the weight loss fat, pure body. And then what they were doing is they were identified that by DEXA. And what was interesting is the group that had just an exercise prescription put in on placebo, and one who'd had liraglutide, but no change in exercise, just regular loss, the patients that had exercise prescription and placebo had a greater reduction in percentage body fat. So that was the first indicator, like, well, these things by themselves, we're seeing good numbers, but what are we losing? Now, to be fully transparent, in that same trial, they did a combination of exercise prescription and liraglutide, and that group far and away lost the most percentage body fat.
Right.
But it did show that the missing link to so much of the clinical implications of this is when we just use it haphazardly as a way to lose weight. And we're not looking at the real implication it can have from overall body composition and long-term effects of muscle loss.
Is there a loss of lean body mass if you're not on such a low-calorie diet? You take the drug, does it promote the loss of lean mass in and of itself?
Not by itself, it does promote actually an improvement in just at least on a cellular level, the body's ability to acquire and utilize nutrients, or usually like macronutrients. But what we do see, unfortunately, is what the benefit of the medication is improving oral intake in terms of just hypercalorism. So patients just don't want to eat as much. Unfortunately, what we've noticed is that with that hypocaloric intake, or that kind of I'm not very hungry, the thing that they're eating the least is protein. And as we know, we don't store any protein. And then what we are looking at from a clinical standpoint, and I'm sure also from an athlete standpoint, is what's going to be the long-term effect of a patient population in which we have acute weight loss, don't meet the protein demand, amino acid demand, are not engaging in enough resistance training, and how is that going to degrade them in terms of their physical ability just to do day-to-day activities once they reach, like you were saying, Dr. Antonio, if these patients are on it for 20, 30, 40 years, wow. What is that, a patient who started when they're 30, what are they going to look like at 70? How much loss are we looking at? We don't have the data yet.
Yeah. And another thing that's interesting with regards to the physique world is, obviously enhanced athletes are going to be using polypharmacy. So you're going to have compounds like clenbuterol, potential growth hormone, other compounds, of course, the androgens. So, now you add a lot of other variables in there. So you don't really know, what's going to happen. And, is it going to maybe help compensate for some of that loss of lean tissue because you're on these other compounds? You may or may not, because they're going to will themselves to eat the protein like the average person may not be doing. So that is very interesting. So there's a lot of other variables to look at.
Go on.
I'm sorry. Go ahead, Tony.
I would imagine though, because you Dr. D, you mentioned the slowing down gastric emptying, and so maybe that's part of the aversion to protein, right? Being the digestive costs being a little bit longer, a little bit slower. So maybe that's part of what, when people are eating it, maybe there's greater distress. Is that possible? Gastric distress?
Most definitely. And the thing that we try our best, at least at the deck plate level, of obviously we want to get the benefit of these medications for the patient, but sometimes if the goal is just weight loss, irrespective of the physical, what they lose, sometimes some physicians try to push to the limit of what we should be prescribing. There's caps that we can get to, but instead what we need to do is, what I try to do in my clinic is I try to reach a level that, okay, you're feeling an improvement in your desire for driving of this food. I guess you could say the term that's used a lot is food noise. We've had those people, those patients, even those athletes who, for lack of better terms, they just are always wanting to graze, are always wanting to snack, they're always wanting to do this. There's just always this inherent drive to eat something. And as we increase in dosage, we're seeing that people's desire to eat less and less protein is kind of also becoming higher. So really what we should be trying to do is find that happy dosage where we're getting the control, they're getting better, but they're still able to maintain enough oral intake to meet protein demand. And sometimes that means starting at the lowest dose and staying there.
Right.
Tony, I can certainly confirm the when you're full, you don't want protein, but you're more than happy to have like a sugar-filled dessert. I mean, I do that almost at every dinner when I go.
Yeah.
Yeah, and I was going to say, from a bodybuilding perspective, getting down to that, single digit, sub 5% body fat, sub 6% body fat, I mean, there's always a whole band going on in my head, for sure. There's an orchestra going on all the time. Can't shut it off.
That's too funny. Hey, this is sort of a philosophical question, really, for any of you. And since, Edwin, you work, you focus primarily on the obese population and whatnot. Philosophically, when you get someone who's overweight or obese, and obviously the lifestyle patterns that they've adopted are just not the best lifestyle patterns. And do you approach it with, there's sort of two schools of thought that I've watched on social media arguing about this. One is, shouldn't you try to exercise and change your diet first before you get on a drug? And there's the other school of thought, and maybe I'm simplifying this, but there's the other school of thought that says, why don't give them this drug? It'll precipitate some weight loss, and then we can introduce lifestyle issues. And being a cynic, I'm like, first of all, no one's going to change your lifestyle. Once they've gotten to that point, it ain't ever happening. So in a sense, is the drug your only alternative? That was kind of a ramble, but you know what I'm saying. Edwin.
For sure. I'm of the first class. But that, again, it's my background. My background is exercise physiology. I do believe that too many times have we seen an individual come into an office and say, I want the pill to fix this. Now, this is a tool in the toolbox, and it is one hell of a tool. I'm a huge believer in this category, but I'm also very much against the idea that we promote it as lightning in a bottle, or the next, or the magic bullet, or whatever have you. We have to actually have a sit-down conversation and see where the mindset is of the patient, to say, are you really ready for change? Because this is going to change. Things are changing. And more often than not, I've had patients who, depending over time, they kind of get on board. But I know there's a lot of patients I've also had, which I've had to say, we're not starting this yet. When they say, well, no, I know how this works. I'm going to eat less, and that's all that matters. No, but you're right. I think what we've seen when it comes to who prescribes it, and I'm being very generalized here, is who it comes to the level of the practitioner and how comfortable they are, not only prescribing a medication, but also prescribing exercise, prescribing dietetics, prescribing lifestyle change. And sometimes, and I've known plenty of docs who will openly say, if they're being honest, I don't know anything about that. I don't know how really to create an exercise protocol. I don't know how to track that. I don't know how to meet these things in that. So they try to refer out, and sometimes patients go, sometimes they don't, but they know pharmacology. They know how to write a prescription. They know how the medicine works. So they stay in their wheelhouse. So I think that kind of drives a lot of where the person goes in which direction they think. What do you think, Dr. Escalante?
Yeah, I'm kind of on the fence on it, because I agree lifestyle changes are important, and my first line of defense. However, sometimes people need a little incentive to do that. And sometimes maybe because they're doing that, they may change their lifestyle. And kind of like you said, because the drug may actually help them eat less, that by default is going to help them kind of change their lifestyle a little bit. So I'm kind of on the fence a little bit. It may be something where you could maybe prime the wheel a little bit and say, hey, let's make these certain changes. So maybe get a certain amount of steps for a 6-week period of time, 8-week period of time. Let's get you to lose, X amount of body fat or over a small period of time, maybe increase protein intake to a certain level for a period of time. Naturally, getting those things together are going to probably prime the wheel a little bit, and then prime the pump per se. And then once you do, that next phase would be, now we're going to introduce that. So you put that as a carrot to dangle it. And that may be a good strategy, but everybody's so different. I think individuals, some people are ready to change and some are not. And like Dr. Antonio said, I mean, some people are just, they've already gotten there, and they don't care. They don't want to change. So, I mean, they say they want to change, but the reality is they don't want to do what it takes to make those changes. So, and I think that's the art of, being a coach or being a dietitian or a physician is, we can get them, we know what well is going to work and how to drink the water, but getting them to drink that water, that's the art of the advising and the coaching and the being a clinician.
Yeah, I think for the four of us, we're so used to being around people that train hard, that are cognizant of how they eat, that once we get out of sort of our bubble, I guess part of it is, I don't understand why other people can't do that when I'm surrounded by people. That's all they do. I mean, they train, they eat well, and they take whatever supplements work. So I guess, it's one of those things where I guess I'm not positive that in the long run, will the 70% overweight and obesity rate actually drop because of the presence of this drug? I don't know. I wonder. I mean, because ultimately, if that doesn't change, then really the drug isn't doing anything from a population standpoint.
I will say that the thing that I'm the most excited about, if I had to say anything I'm excited about that gives me hope for the future, is what patients tell me they experience without me asking them. This is what I mean, is I've had several patients who say, I just don't feel like I need a snack right now, and I don't understand why. I was looking at, after about 2 or 3 weeks, I'm looking at my food. My mind tells me, I know I was eating this much, but I just don't want it. So and it's almost like they're almost concerned, trying to understand it, because it doesn't make any sense to them. And what we're thinking, what we're postulating amongst all the potential mechanisms in which these medications could potentially be causing this, is that it's resetting the area of the brain, or at least assisting in realizing what energy homeostasis actually was. Just like diabetes is a dysregulation of the body's ability to identify insulin. The question is because these medications are crossing the blood-brain barrier, and because they're saturating the area of the brain that is meant to be doing this, did these patients have a dysfunction in the identification of endogenously produced GLP-1? And that area, that biochemistry of that food drive has been just out of whack. And now that we're trying to basically give that which they did not have, or allow that to be stimulated that the way it couldn't be before, are they now going to be able to, like Dr. Escalante said, establish better habits now that their brain will let them establish those habits? That's kind of where the curiosity is right now. So
that's fascinating. So could this be also, and are we looking at, like, I don't know, better leptin sensitivity, or the, even orexigenic and the anorexigenic receptors in the hypothalamus upregulating back again to potentially what a positive baseline would be? Is that one area of the brain that might be involved in this? Or?
Absolutely. And it's just like you had mentioned, that area of the brain is not only that we realized that GLP-1 is produced in the GI tract. We now know that GLP-1 is produced locally, actually in that area of the brain. Okay. And the curiosity right now is, when leptin was first being looked at, and they thought that was going to be the next big thing, they realized that there's a significant amount of resistance to it in obese population, kind of left it to be a little bit of a moot possibility of treatment, even though there's a new trial that came out in the New England Journal talking about a mutant variation of leptin that's actually could potentially have been, for some patients, have been kind of a partial antagonist, which is really fascinating, but that's a whole nother gambit. Yeah. The curiosity is right now with this is, are we being able to take advantage of those areas of the brain, but we're treating it with a medication that the brain hasn't reached resistance in. It just wasn't getting stimulation in the first place, or it was getting a improper stimulation. Because looking at the bariatric population, we were wondering the same thing, like, why are these people losing so much weight? Yeah, we chopped out their stomach, yay, but why are we getting improvement in their diabetes, and why are they losing so fast? It has to be something else. And what we've learned, the area of the stomach or the GI tract in which GLP-1 is produced is very distal. It's actually close to the ileocecal valve. That's where the L-type cells are very, very populated. But they're stimulated by food. It's a postprandial response of carbohydrates, fats. So it takes a while to get down there. Well, when you separate, you do a Roux-en-Y gastric bypass, you're dropping down, you're getting a much faster hit of macronutrients to that area. And what we've seen is those patients have had a huge uptick in GLP-1 endogenously produced. Wow. So now we're wondering, heck, is that what kind of been a driving force for them in the first place? So
fascinating, yeah.